for today is why torch infections are more important now. Revision. It is a DNA virus and it belongs to human herpes family, herpes virus family. It has similar biological properties of latency and reactivation as of other members of herpes family. It affects 0.2 to 2% of all live births and is the most common cause of intrauterine infection. It is the major non-genetic cause of sensory neural hearing loss and neurological disability in infants. The prevalence of CME varies by population and various other demographic factors ranging from 40 to 100%. A systematic review has estimated CME seroprevalence in women of childbearing age to be as high as 86%. The highest prevalence rates are in the regions of Eastern Mediterranean, Western Pacific, African and Southeast Asian regions, approximately 90%, and lowest rates in Europe, 70%, and America, 79%. The seroprevalence of CMV is higher in residents of developing nations and those with increased parity, lower socioeconomic strata, age more than 30 years, those working in daycare settings, or parents of children less than 3 years. The rate of seroconversion in seronegative women during pregnancy ranges from 1 to 7%. CME infection in pregnancy can be classified as either primary or non-primary. Primary infection is defined as acquisition of CMV virus during pregnancy in a person with no pre-existing CMV-specific immunoglobulin G antibodies. Diagnosis is based on seroconversion, that is newly detectable CMV-specific antibodies during pregnancy. The main causes of primary infection acquired in pregnancy are sexual transmission and contact with young children. Horizontal transmission among children or from children to adults is highly prevalent in daycare centers where it spreads through saliva on hands or toys. Other routes of transmission are contact with secretions like vaginal, cervical, seminal, saliva, or fluids like blood or urine. Non-primary CMV infection or secondary infection is defined as one when the virus is first acquired before pregnancy and the mother develops antibodies against CMV before pregnancy. After the infection has subsided, the virus becomes latent and resides in the host. In such cases, infection during pregnancy may be due to reactivation of the latent endogenous virus or reinfection with a new virus strain. There are reports of variable rates of viral shedding from multiple sites after primary or non-primary infection. Primary CMV infection is asymptomatic in 75 to 95% of the cases. Others may show symptoms of mild mononucleosis or flu-like syndrome with non-specific symptoms like fever, malaise, fatigue, upper respiratory tract infections, headache, and cervical lymph node enlargement. 1/3 of these patients present with skin eruptions or rashes. These patients may have lymphocytosis and elevated alanine transaminase and aspartate transaminase in 40% of the cases. With advanced gestation, cervical shedding in pregnancy increases from less than 5% in first trimester to up to 30% in third trimester. Diagnosis of maternal infection. The gold standard for diagnosis of maternal primary infection is serology. Routine prenatal screening is not recommended. Indications for testing a pregnant woman for CMV infection are as follows. Like patients with flu or mononucleosis-like syndrome with negative Epstein-Barr and influenza virus tests, or in cases with features of hepatitis with negative hepatitis A, B, and C reports. This will detect only 10% of the cases who are symptomatic. Suspected intrauterine infection testing is indicated in cases of fetal anomalies suggestive of CMV infection as detected on routine antenatal ultrasound. Diagnosis of maternal infection. Seroconversion of CMV IgG in paired acute and convalescent sera at an interval of 3 to 4 weeks is diagnostic of new onset acute infection. Unlike other viral infections, detection of IgM antibody is not diagnostic in CMV because IgM can remain positive for almost a year after acute infection. And also in some cases, it is present only in 75 to 90% of acute infections. It can become positive in cases of reactivation or reinfection with a new strain and can be false positive in cases of other viral infections like Epstein-Barr virus infection. Therefore, it is difficult to distinguish between cases of primary and non-primary maternal infections in the absence of documented recent seroconversion, since IgM and IgG can be elevated in both. So, role of IgG avidity. Antibody avidity is a measure of the strength by which a multivalent antibody binds with an antigen. It can be helpful in having an idea about timing of CMV infection. After recent primary infection, IgG antibody shows low affinity for antigen. Afterwards, the antibody slowly matures and shows high avidity 3 to 4 months later and can persist for many years. An avidity index of more than 60% suggests past, that is more than 3 months, or secondary infection. An index of less than 30% is highly suggestive of recent infection, that is less than 3 months. So, in short, the interpretation of CMV serological testing. So, antibody status, if both IgM and IgG are negative, so IgG avidity testing is not required. That means the patient is not infected with CMV. If IgM is positive and IgG is negative, then also IgG avidity testing is not required. That means it is false positive and a repeat test is required in 2 weeks' time. If both IgM and IgG are positive, that is the avidity is low, that is less than 30%, that means it is recent infection. And if IgM and IgG both positive and the avidity is high, that means it is past infection. IgM negative but IgG positive in low titers, that means recent infection. IgM negative and IgG positive with high avidity, that means past infection. So invariably we don't have to confuse. If both the IgM and IgG antibodies are positive, we have to go for IgG avidity test to confirm. Transmission of infection to fetus. The rate of congenital infection is much higher in women with primary infection, up to 50%, than in women with non-primary infection. In those cases, it is only less than 2%. Vertical transmission of infection can occur in utero, intrapartum, or during postpartum period. The virus can cross placenta and is able to replicate in placental cytotrophoblasts and multiple embryonic or fetal tissues, including renal tubules. Transmission during delivery can occur through ingestion of secretions from cervix or vagina. Postnatal transmission can be because of breastfeeding or horizontal transmission. Intrauterine transmission carries risk of greatest sequelae as compared to intrapartum or postpartum transmission. The risk of in utero transmission increases with advancing gestation from around 40% in first and second trimester to more than 60% in the third trimester of pregnancy. However, incidence of sequelae decreases with advancing gestation with favorable outcomes for those infected in the third trimester. Also, non-primary infection is associated with less severe fetal disease. Ultrasound findings when the fetus is infected, we can see either periventricular calcifications, microcephaly, ventriculomegaly, pseudocysts in the periventricular or adjacent to occipital or temporal horn, cerebral hypoplasia, fetal growth restriction, hypoechogenic bowel, hyperechogenic bowel, hydrops, amniotic fluid abnormalities, hepatosplenomegaly and placentomegaly can be there. Diagnosis of fetal infection is by amniocentesis. It is offered in cases of confirmed primary maternal infection or suspected fetal infection based on ultrasound findings. The demonstration of cytomegalovirus or viral genome in the amniotic fluid is diagnostic of fetal infection. The timing of amniocentesis is very crucial to avoid false negative results. It should be done at least 7 weeks after the onset of maternal infection. I repeat, it should be done at least 7 weeks after the onset of maternal infection and after 21 weeks of pregnancy. The reason being, the fetal urinary system matures after 20 weeks and is able to excrete virus through the urine into the amniotic fluid after 20 weeks. It takes around 6 to 8 weeks for virus to infect placenta, replicate, transmit to the fetus viral replication in fetal kidney, and excretion into the urine. So this is a busy slide, but I think I have already enumerated that when IgM antibodies are positive, uh, then we have to go for first IgG antibodies, and if they are positive, then we have to go for avidity testing, and further testing is required to confirm whether it is a recent or a past infection. Diagnosis of fetal infection. Diagnosis of fetal CMV infection is made by culture and polymerase chain reaction, testing of amniotic fluid. Sensitivity of PCR is as high as 70 to 100%. In case of positive results, DNA viral load can be quantified. Chordosynthesis is not recommended because of poor sensitivity of the test, because of the maternal contamination. So chordosynthesis is not to be done. Ultrasound, 2 to 4 weekly serial ultrasound examinations have to be done in case of infected fetus. There can be a lag of 3 or more months for the development of ultrasound abnormalities after maternal infection. Out of ultrasound abnormalities, echogenic bowel may be the first indicator of CMV infection. The most characteristic finding of fetal CMV infection on ultrasound is bilateral periventricular calcifications. Fetal MRI may be added to ultrasound for better detection of neurological abnormalities. Prenatal treatment. Routine antenatal care has to be provided. Supportive therapy is offered for symptomatic relief. Antiviral drug used in pregnancy is valacyclovir. Valacyclovir is a prodrug. Its active drug is acyclovir. Valacyclovir has higher oral bioavailability as compared to acyclovir. Vaccine is not yet available and is not recommended. Prevention of CMV infection can be done by teaching all pregnant women to have good hygiene practices to reduce the risk of CMV infection. So to conclude, congenital CMV infection is a predominant non-genetic cause of hearing loss and other mental disorders. IgG avidity test helps in facilitating the diagnosis of primary maternal infection. Counseling of parents is a challenging task as there are no reliable prognostic indicators or established therapies. However, routine CMV screening for pregnant women is not recommended. Rubella infection in pregnancy. Rubella virus is a single-stranded RNA virus. It is a member of the family of Togavirus, genus Rubivirus, with human beings are the only known reservoir. Transmission is facilitated by direct droplet contact from nasopharyngeal secretions, followed by replication in the lymphatics of the upper respiratory tract and hematogenous spread thereafter. It usually causes a self-limiting infection, but in cases of transplacental viral spread, can lead to devastating fetal effects, including congenital rubella syndrome. The incidence of rubella has declined from 0.45 per 1 lakh in 1990 to 0.1 per lakh in 1999. Ever since the introduction of the comprehensive vaccination program in 2004, congenital rubella syndrome has rarely been reported in USA. In countries with not such vigorous vaccination programs, cases of rubella infection and subsequent CRS are still witnessed. So clinical manifestations. Acquired rubella is a mild self-limiting illness with characteristic exanthem. It remains asymptomatic in 25 to 50% of the cases. Symptoms commonly appear 14 to 21 days after the initial inoculation and consists of low-grade fever, conjunctivitis, coryza, sore throat, cough, headache, and malaise lasting 1 to 5 days before the onset of rash. Generalized tender lymphadenopathy, commonly involving suboccipital, post-auricular, and cervical nodes, may also be seen, particularly during the rash. Approximately 20% of those infected develop discrete rose spots on the soft palate called Fauchermeier spots just before the onset of rash. The typical rubella rash is erythematous, maculopapular, and may be mildly pruritic, evolving into pinpoint papules over time. It characteristically begins on the face, spreading to the trunk and extremities within hours and lasts approximately 1 to 3 days. Polyarthritis and polyarthralgia may develop 1 week after the rash and is more commonly seen in female adolescents and adults. Classically, the hands, knees, wrists, and ankles are affected in a symmetric pattern with associated pain and stiffness for 1 to 4 weeks. But in most of the cases, it is the patients get recovered. It doesn't have a longer lasting sequelae. Other rare complications like bleeding disorders due to thrombocytopenia and encephalopathy may be present. Maternal fetal transmission occurs transplacentally and spreads through the vascular system of the developing fetus, ensuing cytopathic damage to the blood vessels and ischemia in affected organs. Fetal infection is chronic, persisting throughout gestation and after birth. The risk of maternal fetal transmission varies depending on the time of maternal infection. Structural cardiac and eye defects typically result when maternal infection occurs before 8 weeks, whereas hearing loss may be observed in maternal infections until 18 weeks of gestation. Congenital defects are unlikely if maternal infection occurs after 18 to 20 weeks of gestation. Fetal infection rates can be as high as 80% in the first trimester, dropping to 25% in late second trimester, and increasing again in the third trimester from 35% at 27 to 30 weeks to nearly 100% for exposures beyond 36 weeks. However, congenital rubella syndrome occurs when the maternal infection is in the first 16 weeks of pregnancy. Little if any risk of congenital rubella syndrome is associated with infection after 20 weeks gestation, while intrauterine growth retardation may be the only sequelae of third trimester infection. Rubella infection in pregnancy is the most common vaccine preventable cause of birth defects. So, we have to note this point that it is the preventable cause of birth defects. So, we have to insist for immunization of almost all younger age group females, so that when they become pregnant they are not troubled with the rubella infection. If infection occurs before 16 weeks, patient should be counseled regarding fetal transmission and offered pregnancy termination. Beyond 20 weeks, management should be individualized and patient counseled regarding the delayed consequences of rubella infection. Diagnosis is done by enzyme-linked immunoassays, which are sensitive, accurate, easily reproducible, and measure rubella-specific immunoglobulin IgG and IgM antibodies. Immunofluorescent antibody assays are also sensitive and rapid. Immunoglobulin M IgM, as in all infections, assists in diagnosis of acute infection, but IgM may persist for a long time after the acute episode and also resurface in cases of reinfection. Evaluation of rubella virus IgG avidity is of value, as low avidity suggests recent infection. So, diagnosis of acute rubella syndrome is best diagnosed by isolation of rubella virus, presence of rubella specific IgM antibodies, fourfold rise in IgG titers between acute and convalescent serum, that is 7 to 10 days of rash onset and then 2 to 3 weeks later appearance of IgG antibodies. Rubella IgM can be falsely positive due to rheumatoid factor, so rubella specific avidity assay is beneficial. Positive rubella culture from nasal, blood, throat, urine or cerebrospinal fluid samples is also diagnostic of the current infection. The virus is generally isolated from pharynx 1 week before to 2 weeks after the rash. Prenatal diagnosis, it has been seen that PCR testing on CVS samples may be superior to standard serological testing on fetal blood. Polymerase chain reaction provides presumptive diagnosis of rubella infection. In addition, CVS sampling at 10 to 12 weeks gestation allows for earlier detection, and decision can be taken early if the fetus is affected for termination of pregnancy. It is extremely difficult to diagnose CRS fetal malformations on ultrasound given their nature. However, workup of any fetus with growth restriction should include evaluation for congenital viral infections including rubella. So, treatment for acute infection mainly involves symptomatic relief using acetaminophen. Glucocorticoids, platelet transfusions and other supportive measures are reserved for complications such as thrombocytopenia or encephalopathy. Use of immune globulin for antenatal patients with acute infection is not recommended. Vaccine commonly used is RA273. It is a live attenuated vaccine which is used world over. Vaccination is recommended for all children at 12 to 15 months and then at 4 to 6 years in conjunction with measles and mumps. Also, women who approach us for prenatal counseling, they should always be advised about rubella vaccine in case they are not rubella immune. They should be counseled regarding taking the vaccine and then avoiding pregnancy for 28 days after taking the vaccine. A single dose of the vaccine administered at age 1 year or more results in measurable antibodies in almost 95% of susceptible population. Contraindications to rubella vaccination include febrile illness, immunodeficiency disorder, history of anaphylaxis to neomycin, and pregnancy. Although rubella vaccine virus may cause transplacental infection, inadvertent vaccination during pregnancy is not an indication for termination. Thank you.